Hello, everyone. So, the focus of my discussion for today is about filariasis. Okay, so we generally call them the filariae. Okay, anyway, these parasites here, class, are also considered as extra-intestinal nematodes. So, I think I have mentioned about other extra-intestinal nematodes last time. So, one of those is your Trichinella spiralis, the one that dwells in the muscles, and also I think I failed to mention this one, the Parastrongylus cantonensis. Okay, the one that causes the disease of what we call as the rat lung worm. Okay, and one of the I think one of the social importance of this filariasis is that it can cause debilitating illnesses. Okay, so it can progress from, for example, inflammation only until such time that the patient's daily routine will be affected already, because as what you can see there in the picture, it involves enlargement of the extremities and also other serious conditions that can really affect the patient and also cause social stigma. And sad to say that most of the people who are affected with this disease are those who are living in the far-flung areas without knowledge or at least awareness of their condition. Okay, and I think in the Philippines, it's common in number one in Panay Island, and one of the provinces also is the Quezon, okay, where it was previously found to be endemic for this filarial parasites. Okay, you can also have the southern Leyte and Sorsogon and a lot of places in the Philippines. Okay, you can find that in the textbook also, the what do you call this, the areas affected by filariasis. And outside, of course, the Philippines, one of the most common places is the Brazil. Okay, that's in South America. Also Africa. Okay, and also in Asia like China, Vietnam, Malaysia, Thailand, Cambodia, and of course our country. Okay, Philippines. Okay, anyway, so the disease, we call it as lymphatic filariasis. Other people call it filariasis. They pronounce it like that. Okay, so lymphatic filariasis. And what you need to know about this lymphatic filariasis is that all parasites have a similar life cycle. And they are called as lymphatic filariasis is because the adults of these parasites are seen in the lymphatic vessels. Okay, the lymphatic vessels. And of course, the offspring of this parasite is what we call as the microfilariae. Okay, the microfilariae. And these offspring, these microfilariae, are usually seen in the peripheral blood and during nighttime. Okay, so again, the adults are seen in the in the lymphatic vessels, and the offspring, the microfilariae, are usually seen in the peripheral blood at night. Okay, and another thing, in the Philippines, I think this is second to psychiatric illness in causing permanent and long-term disability. Okay, so it can affect not only your physical well-being, but also it can impact the psychological aspect of the victim because, again, of how the progression of the disease looks like. Okay, so as what I have said, this is considered as a neglected tropical disease. It's actually global. Okay, globally neglected tropical disease. Okay, and LF class lymphatic filariasis is one of the most debilitating diseases plaguing many tropical countries, the one that I have mentioned. Okay, and the disease again is transmitted by blood feeding arthropod. Okay, such as of course the mosquitoes, but not only that, you can also have the black flies. Okay, and these are just showing you the areas, okay, affected by filariasis. So you can have here, okay, the Brazil, Africa, of course, in Asia you have China, okay, of course, Vietnam, Indonesia also. Okay, so as what you can see there in the picture, okay, that is an adult, okay, filarial parasite can be pulled, okay, from the extremities of the patient. Okay, they're very long, they're visible in the eyes. Okay, but the microfilariae, you can only see them microscopically. Okay, for the filarial nematodes, they can be considered as a subcutaneous parasite. Okay, like loa loa, okay, the African eyeworm. You also have the Onchocerca volvulus. You also have Manzonella streptocerca. Okay, in the serous cavity, okay, you have Manzonella, okay, particularly in the serous cavity in the abdomen. And also, okay, I highlighted the two most common lymphatic filarial parasites in the country, which are again Wuchereria bancrofti and Brugia malayi. Okay, and of course, you have another one, which is the Brugia timori. Okay, and again, the one which are highlighted are the ones that are common in the Philippines. Okay, so for the adult parasites, okay, so for Wuchereria bancrofti class, okay, it's creamy white, long, and filiform in shape. Okay, of course, as what you can see here, the female is longer than the males. And that's also true, okay, when we are talking about nematodes, the females are always longer than males. Okay, and for Wuchereria class, the usual species of the mosquito are Aedes. Okay, so you have the Aedes, like for example, the Aedes anopheles. You also have the Culex. Okay, these are the vectors. The Culex and also, okay, the Aedes and again Anopheles. Aedes and Anopheles. Let me correct my statement. Okay, Aedes and Anopheles. Okay, so these are the common vectors associated with Wuchereria bancrofti, the Aedes and Anopheles, the Culex also. Okay, for Brugia malayi, it is still true that the females are longer than males, but the common vector associated to this one is the Manzoni. Okay, the Manzoni species. Okay, so that is for Wuchereria bancrofti and Brugia malayi. Okay, and take note, the adult females of Brugia and Wuchereria are indistinguishable. Okay, this one class, this just shows you, okay, the filarial adult. Okay, and then another one, okay, that's still a picture showing again the adult parasites. Okay, let's have the offspring, okay, the microfilariae. Okay, for Wuchereria bancrofti, this is the estimate measurement. Okay, anyway, for those who don't know, okay, and for those of you who might be asking, okay, how do we measure the parasite? Because again, we cannot see them, okay, usually through our naked eye. So how can we measure them under the microscope? So in that case, class, let me just inform you that we are using the ocular micrometer. So it's like inserted in the eyepiece in the ocular of the microscope, and then when you peek through the microscope, you can see the grid lines, you can see an image which looks like a ruler, and of course when we move the specimen, we can see and we can measure, okay, the elements that we can observe in our specimen. So that's how we can get the estimate of the measurement of the microscopic structures under the microscope. Okay, so going back, class, Wuchereria bancrofti, okay, is sheathed. Okay, there's a sheath, we call it a hyaline sheath, which is usually longer than the microfilaria itself. Okay, so the sheath is longer than the microfilaria itself. And in the stained blood smear, because again, as what I have mentioned, the adults are found in the lymphatic vessels, whereas the microfilariae are usually found in the blood at nighttime. So in the stained blood smear, class, what you can observe is a central axis, okay, that will show a dark staining nucleus. And that is one of the most important identifying feature of this Wuchereria bancrofti and also other filarial parasites. Okay, and take note, the column of nuclei is arranged in 2 or 3 rows and distinctly conspicuous. Okay, you can see it, okay, in the tail. And of course, it has several curvatures and a graceful appearance. And when they move, they are like snakes. So minute snake-like organisms constantly moving along the RBCs. Okay, especially if you have collected a fresh blood sample. Okay, anyway, for a direct examination of this, okay, ideally you can just capillary puncture. Okay, you can perform capillary puncture to the patient and then directly observe the parasite under the microscope. Okay, and you can see them moving through the along with the RBCs. Okay, so this is the microfilariae class of the Wuchereria bancrofti. Okay, so again, it has this sheath. Okay, so what you can see it. Okay, it's folded there. Okay, and of course, you can see the dark staining nuclei here. Okay, so this is again in stained blood smear. Okay, how about for the microfilariae of Brugia malayi? Okay, for Brugia malayi class, okay, of course, it's shorter than your Wuchereria bancrofti. So just imagine that Wuchereria bancrofti has a longer spelling. So Brugia malayi has a shorter spelling. So it's shorter than Wuchereria bancrofti. So 111 to 230 micrometer. Okay? And of course, just like your Wuchereria, Brugia malayi is also sheathed and it has angular curvature. Okay? With secondary kinks. And this is what is distinct about Brugia malayi. It has two nuclei, okay, two nuclei at the tip of the tail, and usually class, they are indistinct, unlike the Wuchereria bancrofti, which is conspicuous and distinct, okay, and the two nuclei are usually confluent, meaning to say they usually merge, okay, and again, they consist of two rows of nuclei. So this one class, okay, this is a picture of Brugia malayi. So this is the sheath, okay, longer than the parasite itself. So the dark one, that's the parasite. And the faint staining, okay, that is the sheath. And of course, okay, you have these nuclei, usually two nuclei, okay, at the tip of the parasite, and usually they are confluent again, okay, not that distinct. So this one class just shows you the other, okay, filarial worms or filarial parasites. So again, for Wuchereria bancrofti, the habitat of the adults, okay, just like the Brugia malayi, is in the lymphatics. Again, for the vectors, again, Aedes anopheles, the Mansoni or Mansonia species that I have mentioned earlier, and you have the blood specimen, which can also be used for Loa Loa. Okay? Both the Wuchereria and Brugia are sheathed. Okay, but for the microfilariae of Wuchereria bancrofti class, okay, you cannot see nuclei there. Unlike your Brugia malayi, which has again two separate, okay, indistinct and confluent nuclei. Okay, so for Wuchereria class, it's usually nocturnal, so you can isolate or you can see the parasite at nighttime. So that's probably from 10 p.m. to 2 a.m. Okay? And the subperiodic nocturnal belongs to Brugia malayi. Okay? For Loa Loa, okay, this is wrong spelling. So it's diurnal. Okay? So Loa Loa, you can find that in the subcutaneous tissues, just like in the eyes. Okay? The species of the vector, we have the chrysops, okay, the tabanid, or what we call as the mango fly. Okay, it's also sheathed, and the nuclei are continuous up to the tip of the tail. So if I am to illustrate, okay, the Wuchereria bancrofti, for example, this is the parasite. Of course, it's sheathed, right? So it's sheathed. Okay, same with Brugia malayi. Okay, this is the parasite. Okay, it's also sheathed. Okay, for Loa Loa, this is the parasite. Same with the two, it's also sheathed. Okay, but for Onchocerca volvulus, okay, it's unsheathed. Okay, how about for the nuclei? So for Wuchereria bancrofti, the nuclei are absent in the tail. But for Brugia malayi, okay, Brugia malayi, it has two separate nuclei. Okay, For loa-loa, okay, the nuclei are continuous up to the tip of the tail. So you have a lot, okay, more nuclei, okay, as compared to Brugia malai. For Onchocerca volvulus, you don't have nuclei for that parasite. Okay? For Onchocerca volvulus class, you have the black fly. Okay, black fly, Simiolium species. Okay, and for the specimen, you have skin nips or shavings. Okay, because again of the location or the habitat of the parasite. And for the periodicity class, okay, it's non-periodic. So when I am talking about periodicity, I am talking about the appearance of microfilariae in the blood. So is it seen? Can it be seen every night, in the morning, or any time of the day? Okay? So anyway, this just shows you the life cycle of the parasite. Again, as what you can see there, the adults, okay, are found where? Okay, in the lymphatics. So they are tightly coiled, okay, tightly coiled in the lymphatics. And of course, some of the parasites can be found in the subcutaneous tissues again. Okay, and of course, the female will produce microfilariae, okay, and the microfilariae will gain entrance to the blood. Okay, that's why you have here in the circulation. So once the microfilariae is produced by the adults, it will enter the blood. Okay? And what's gonna happen is that these microfilariae, the microfilariae class, okay, will be ingested by the mosquito during a blood meal. Okay, like when the mosquito bites, okay, the mosquito can harbor, okay, the microfilariae, okay, present in the blood. So you can have again the vectors, the Aedes, Anopheles, Culex, and the Mansonia species, Mansonia. Okay? Another thing, so once the parasite, the microfilariae, is already harbored by the mosquito, this one, okay, the microfilariae will migrate to the muscles of the mosquito, and it will develop into first and then second and eventually third larval stage. The third larval stage class, that is what we call as the filiform. Okay, the filiform. Filiform larva. And that filiform larva class will be the one that will be injected by the vector, by the mosquito, let's say, during a blood meal. Okay, and of course, this filiform larvae class, okay, they will migrate, okay, from the muscles, they will migrate to the head of the mosquito, and eventually, they will reach the proboscis, okay, of the mosquito, the one that looks like a thin tube, or the part of the mouth of the insects of the mosquito. Okay, so once the filiform larva already reaches the proboscis of the mosquito, okay, it can enter again the skin of the host, let's say a human person, okay, through a mosquito bite. And then eventually, the larva will go to the lymphatics and they can again enter the neighboring blood vessels. So that's just the simple life cycle of the filarial parasite. Okay? So my question is, what is the definitive host here? When I say definitive host, okay, definitive host, that's where you can find the adult parasite. So the man here class is the definitive host. Okay? And what is the infective stage? The one that infects the definitive host. So the infective stage is the filiform larva. Okay? The infective stage is the filiform larva. Okay? How about the intermediate host, the one that carries the larval stage, the asexual stage of the parasite? So the infective host class, the intermediate host, is the mosquito. Okay? And if the infective stage to the definitive host is the filiform larva, what is now the infective stage to the intermediate host? What is the infective stage to the intermediate host? That is the microfilariae, because that's the one ingested by the mosquito during the blood meal. Okay, but if we are talking about the human person as the host, then the infective stage of that is the filiform larva or the third larval stage. You get my point? Okay, so let's proceed now to the pathogenesis of the filaria. Okay? Usually, class, okay, I have mentioned earlier that this is a progressive disease and the infection is usually acquired in childhood. But then, it can manifest itself, okay, the infection, after a long years, okay? And we call the infection or the clinical presentation of the individual, okay, who grew up, for example, outside the endemic regions and got infected, okay, after migration to endemic region. So we call it as expatriate syndrome. Okay, expatriate syndrome. So this expatriate syndrome class is characterized by clinical and immunologic hyper responsiveness to the mature or maturing worms. And again, the patient can experience lymphadenitis or the inflammation of lymph nodes, and lymphangitis, the inflammation of the walls of the lymphatic vessels. Again, lymphadenitis, that's the inflammation of the lymph nodes. Okay? And lymphangitis is the inflammation of the walls. Okay, walls of the lymphatic vessels. And the patient can have allergic reactions like hives, rashes, eosinophilia. Okay, at the initial infection. Okay? So another one, we also have the term lymphangiectasia. Okay, lymphangiectasia. So this is a common feature in which we refer this to a parasite-induced lymphatic dilatation caused by the adult filarial worms. And it can then progress to lymphangiogenesis. Angio, there is already the involvement of the lymphatic vessels, angio. Okay, lymphatic endothelial cell proliferation and differentiation leading to collateralization. Meaning to say, there is the formation of lymphatic vessels from pre-existing lymphatic vessels. Okay, so like it's in the process of angiogenesis. Like when you are reading about cancer, so you can read a lot about angiogenesis. So when you say lymphangiogenesis, there is the formation of lymphatic vessels from pre-existing lymphatic vessels. Okay? And because of this, there will be lymphatic dysfunctions. Okay? And that can predispose the infected individuals, of course, to secondary bacterial infections. And another one, it can trigger inflammatory reactions like in the skin, in the subcutaneous tissues, and of course, in the long run, it can lead to lymphedema or worse, the elephantiasis, the one that you have, I have projected in the first microscope slide for this discussion. Okay, elephantiasis. Okay, another one is that the lymphatic localization, okay, of the parasite, okay, is very important in the survival of the parasite because the lymph is a less aggressive medium, okay, compared to our blood. So like for example, there are no platelets, there are no complement system, or there are a few coagulation system, or another thing, they don't have granulocytes. Okay, so meaning to say the flow of the parasites there in that site is much less violent, should I say, as compared if they are living in the blood. Okay, so that's why the parasites can survive longer and can develop progressively because of the characteristic of the lymphatics. Okay? And then another one, this lymph angiogenesis, as mentioned here, is induced by live filarial parasites or filarial antigen. Okay, so let's talk about chronic lymphatic filariasis. Okay, so there will be fibrosis or the thickening or the scarring of the tissues and cellular hyperplasia in and around the lymphatic walls. So meaning to say, there is increased reproduction, okay, or should I say reproduction rate of cells which can cause, of course, organ enlargement. Okay? Another thing, this contributes to edema and collagen accumulation. Okay? And of course, there will be blockage in the lymphatics. So because of dead and decalcifying worms. Okay, like the gross pathological lesions, there will be pain and swelling, and exposure to Wolbachia released by dying worms induces also inflammation. Meaning to say, the amount of exposure to secondary bacterial infections class, and of course the magnitude of host immunity the to the developing larvae of filarial parasites, or to this bacterium, to Wolbachia, okay, will increase the risk of development of chronic diseases. Okay, so this one class, if you heard about this one, this is a genus of bacteria which of course infects arthropod species, okay, like insects, of course, and also some nematodes. Okay, it's one of the world's most common parasitic microbes. Okay, and it's possibly the most common reproductive parasite in the biosphere. Okay, so that's Wolbachia. They commonly infect insects. Okay, and that includes mosquito. Okay, for the clinical spectrum of lymphatic filariasis, okay, it can start from asymptomatic microfilariemia, okay, the parasite's already in the blood, and then ADLA, acute dermatolymphangioadenitis, okay, and then acute filarial lymphangitis, lymphedema and elephantiasis, genitourinary lesions, or what we call as the hydrocele, tropical pulmonary eosinophilia. So that already includes the lungs. Okay, anyway, for asymptomatic microfilariemia, okay, there is no obvious clinical signs of the disease. Okay, however, the individuals serve as the reservoir for mosquito. Meaning to say, since the parasite is already in the blood, they have the capacity to transmit the infection. Okay, and then infected individuals appear outwardly healthy. Okay, remember, the parasite can develop there in the lymph vessels, okay, and then they can grow, and then they can infect the blood, but then the patient might appear normal, might appear healthy, but they may actually have hidden lymphatic pathology and kidney damage already. Okay, so we call it as endemic normal. So meaning to say, they harbor the antigen in the blood, okay, instead of microfilariae. Okay, so endemic normal. Okay, another one. How about the ADLA? Okay, ADLA, acute dermatolymphangioadenitis. So most common acute manifestation of LF with recurrent attacks. Okay, so clinical description similar to erysipelas and cellulitis. Erysipelas class is a bacterial infection in the upper layer of the skin, and this is usually caused by group A streptococcus. Okay, like the Streptococcus pyogenes. Okay, when you say cellulitis, there is inflammation of the subcutaneous connective tissues. Okay, and then another one, okay, this one class, this just shows you acute dermatolymphangioadenitis. Okay, as what you can see, there are red areas there. Okay, next one. How about this one? Acute filarial lymphangitis. So this is a rare manifestation caused by adult worms that died spontaneously or after treatment of DEC. So this is diethylcarbamazine. Okay, diethylcarbamazine. Characterized by lymphangitis that progresses distally along lymphatic vessels, producing palpable cords. So when you touch the skin of the patient or you palpate the skin, you can feel the hardened lymphatic vessels, okay, because of this lymphangitis. Okay, next one. How about this one? Lymphedema, and there is already elephantiasis. Okay, so the most common chronic manifestation class of LF is lymphedema, which again progresses to elephantiasis. Okay, so most chronic manifestation, lower limbs are commonly affected. However, the upper limbs and genitalia may also be involved. So for female patient, the breast and genitalia involvement are also common. Okay, next one. Sometimes class in some references, they counter, what do you call this? They can sometimes use the two words like interchangeably. Okay, that's the term there. However, lymphedema, okay, there is inflammation, but the progression of the disease, a more serious inflammation of, or a more serious lymphedema is the elephantiasis. Okay? So anyway, these are the different stages of chronic lymphedema. Okay, this is proposed by Dreyer et al. Okay, in 2002. Okay, so Dreyer et al. Okay, Dreyer et al. So the stages, you have stage 1 to 7. So for stage 1, okay, swelling increases during the day but is reversible once the patient lies flat in bed. Stage 2, swelling is no longer reversible overnight and the patient may experience acute attacks. Stage 3, you can see shallow skin folds. Okay? Stage 4, the knobs, okay, present in the affected area can be seen already, and these are, okay, the knobs are the lumps or the protrusion in the skin, okay, that predispose the area to trauma because it can be wounded or it can be lacerated when the disease progresses. Okay, and in stage 5, there will be skin folds where the base can no longer be seen. Okay, folds are actively opened by hand. Okay, so I hope it's understandable. Okay, stage 6, mossy lesions are present which leak translucent fluids already. So there is already open wound. Okay, stage 7, the patient is unable to adequately or independently perform daily activities and foul-smelling discharges can already be seen in the affected area. So let's have the stage 1. Okay, so the swelling reverses at night. Okay, but again, reversible once the patient lies flat, okay, on the bed. And then there are no skin folds and the skin is smooth and normal looking. Okay, just the swelling, okay, at nighttime. Okay, stage 2, swelling not reversible at night. So for stage 1, the swelling reverses at nighttime when the patient lies on his bed. Okay, for stage 2, no longer reversible. The skin folds are still absent and the skin still looks smooth and normal. So this is just the one that differentiates stage 1 from stage 2. Okay, for stage 3 class, okay, the swelling again is not reversible, but there are already shallow skin folds. Okay, so these are the folds where the base can still be seen, as what you can see here in the picture. So the base can still be seen when the patient like moves the legs or the foot and the folds opens up, okay, in layman's term. Okay, so what you can see here are lines and creases. Okay, like shallow folds. Okay, but the skin still is smooth and normal. Okay, for stage 4, what is distinct here are the knobs, the protrusions, the nodules, okay, which cannot be seen from stage 1 to 3. Okay, and the skin folds are still shallow. And these knobs class, these protrusions, these nodules predispose again the affected area to trauma because it can be wounded again, is what I have mentioned. Okay, for stage 5, deep skin folds are ready. Okay, so meaning to say the base can no longer be seen, and as what you can see there, because there is already enlargement, you can actively open the folds by your hand. Okay, and the skin is still smooth but irregular looking already because of these folds, which again the base cannot be seen. For stage 6, okay, you can have mossy lesions, okay, or what you call as the wart-like lesions, okay, on the foot or on the top of the toes. So the mossy lesions class are present because of the clustering, okay, of the small and like elongated or rounded, the mossy lesions, okay, can be seen as small lesions or elongated lesions or rounded lesions, And of course, you can see leaking translucent fluids from these lesions. Okay? And of course, how about the skin folds? It was not mentioned here. So the skin folds, because there are already warts or mossy lesions, the skin folds are already absent. Okay? Because they're already deep. Okay? So here, the skin folds are already absent in stage 6. And of course, okay, stage 7, deep skin folds. So the patient here, is what you can see there, will be unable to adequately or independently perform daily activities. And of course, there will be foul smelling discharges. Okay? So the patient needs already help for his or her daily activities, such as walking, bathing, like using the bathroom, or the patient will be dependent to his or her family members, or of course other healthcare providers. Okay, how about this one? Okay, this already involves the lungs. So this is what we call as occult filariasis. Okay, microfilariae cannot be found in the blood but may be found in the tissues. So in short, the clinical manifestations are not present. Okay? And then the syndrome is brought about by the immunologic hyperresponsiveness to filarial infection. Okay, and because of this TPE class can progress to chronic pulmonary fibrosis, and of course, worst is respiratory failure. Okay, and because there are inflammations everywhere, okay, one of the tests that is usually abnormal is ESR. So the ESR is elevated. Okay, and you have hypereosinophilia also, and lung function again is impaired. Okay, because of fibrosis. Okay, which can lead again to respiratory failure. Okay, characterized by paroxysmal nocturnal cough. So that's one of the signs. Okay, how about this one? When we say hydrocele, it's different from chylocele. Okay, chylous, okay, opaque fluid, milky fluid, hydrocele, like clear or straw-colored fluid. Okay, it can accumulate in the closed sac of the testis. Okay, and sometimes it can develop, okay, to chylocele, where the fluid is already milky in appearance. Okay, because of the presence of lymph. Okay, another one. Okay, what I need to mention is that the hydrocele class is more common for Brugia malayi. Okay, Brugia malayi. Okay, this one class also. Okay, you can feel the thickened cord. Okay, these are worst illnesses. Okay, so there will be deformities. Okay, like this one also is very debilitating class. Okay, for the lower extremities, these are the different pictures of the patients with filariasis. So that's why, okay, it's debilitating. It's second to psychiatric illness because of how the conditions might present, okay, progressively. Okay, this one, it affects the arm, the upper extremities. This one class, okay, also for women, the breast can be affected. Okay, the faces can be affected also. Okay, such as these people. And again, since there is chylocele, okay, inflammation, involvement of the blood, involvement of the lymphatic vessels, so you can have chyluria or hematuria. Okay, so the rupture of lymphatics, especially, okay, if it involves already kidneys, okay, it might produce chyluria. Okay, and of course, if it already involves the kidneys, you can have glomerulonephritis, for example, and also that can progress or can develop to hematuria. Okay, so for the diagnosis, okay, the time of the blood collection, okay, in order to perform wet smears or thick blood smears is between 8 p.m. to 4 a.m. because again, they can either be nocturnal or subperiodic nocturnal. Okay? Another one, if you cannot see the microfilariae yet, Meaning to say, it can be, number one, there is a low intensity of infection yet. Okay? Or maybe there are dead worms. Okay? That's why you cannot find them in the blood. Or maybe the lymphatics are obstructed. Okay? Next one, how about this one? The DEC provocative test. So it's 3 milligrams per kilogram DEC, that's single dose of DEC, diethyl carbamazine. Okay, so this medication class will stimulate the microfilariae into coming out to the peripheral circulation, allowing blood smear collection even during daytime. Okay, so that's why provocative test. It will enhance the recovery of microfilariae in the blood during daytime. Okay, another one, you can have immunochromatographic card tests. Okay, so there are card or kits, okay, like this one, CFA. So it detects the CFA, circulating filarial antigen. I don't know if this is common in the Philippines, but of course, maybe if the patient is found to have filariasis, okay, the hospital or the laboratories can coordinate with the government, to the DOH, to really verify and to confirm the diagnosis. Okay? So one of the test kits again is the circulating filarial antigen detection. That's immunochromatography technique, which is sensitive and specific. And this is also one of the tests, okay, that is very helpful in the diagnosis of filariasis. It's actually the gold standard for diagnosing Wuchereria bancrofti infection. Okay? Next one, you can have molecular cynomonitoring of parasites in the pools of mosquitoes. So medtechs don't do this one. It's usually the epidemiologist or the doctors doing research, or other people, okay, who studies mosquitoes and other arthropods. Okay, so this one class is just a table, okay, comparing Wuchereria and Brugia. And again, as what I have said, Wuchereria bancrofti is longer, okay. The cephalic space, it's 1:1 shorter. Brugia, it's 2:1. In GEMSA, the sheath class of Wuchereria is usually faint staining or sometimes unstained. But for Brugia, that's pink. Okay? The nuclei, again, as what I have mentioned, for Brugia, regularly spaced, separately illustrated. Irregularly spaced for Brugia and overlapping. Terminal nuclei, again, there is no nucleus in the tail of Wuchereria, but 2 nuclei. Okay, conspicuously spaced and confluent for Brugia. Okay, appearance in the blood film, smoothly curved and kinky for Brugia. Okay, the in and corpor length, you have 34 micrometer for Wuchereria, longer than Brugia malayi. So this is letter B small and letter M small. Let me just correct the correct way of writing the scientific name. Okay, this one, what is this one? Okay, you can see 2 nuclei at the tip of the tail. So this is Brugia malayi. How about this one? Okay, still confluent nuclei, Brugia malayi. For Wuchereria bancrofti, no nuclei at the tip of the tail. Okay, another one, the sheath here appears to be unstained. That's why there's like a halo there, okay, surrounding the parasite. Okay, how about this one? So you can't find nuclei here, so that is Wuchereria bancrofti, and other than that, again, the sheath is faintly stained here. This one is still Wuchereria bancrofti. This one, okay, still, oh no, this is already Brugia malayi. Okay, although you cannot see the nuclei here because again the sheath is somewhat folded. Okay, but this is Brugia malayi owing to this pink sheath, okay, of the parasite. And for the treatment, you have DEC, okay, diethyl carbamazole, ivermectin, and diethyl carbamazine. Okay, so it can be effective class both in adults and in microfilaria. Okay, this is actually the drug of choice. Again, diethyl carbamazine. Okay, and next one class during COVID, this this has been one of the issues, right? The use of ivermectin. So for ivermectin, when we are talking about filarial parasites, it directly acts on microfilaria. Okay, but it is not effective for adults. So when we are talking about TPEs, so we can't use ivermectin. Okay, and for albendazole, treatment also for ascaris. Okay, so it cannot kill the microfilariae, but it will kill or it will treat the adult worms. Okay, next one, class, these are just the practices of the patients. Okay, because they have large, tender, and painful lymph nodes, usually they will submerge their leg in a warm water. Okay, so to like relieve the pain, and of course to wash the lesions. Okay, or they can take antibiotics also. Okay, this one, class, there is peeling and tenderness of the skin. So this is a classic sign of ADL. Okay, also this one, there are already lesions present. Entry lesions, class, such as this one, can be seen already. It can it can sever the patient, it can wound the patient. Okay, you can have nodules, warty lesions, entry lesions. Worse is this one or that one. Okay, so how do we prevent this one? Of course, for filarial prevention, very simple. Okay, use of mosquito nets, insecticidal residual spraying, prevention of stagnant water, or elimination of those kinds of practices that can enhance the growth of mosquitoes. Or we can make use of Bacillus sphaericus. Okay, you can make it as a spray, okay, containing polystyrene beads to seal the latrines to eliminate or to reduce the Culex vector. Okay, and of course, health education, especially for those people where who are living, I mean, in endemic places. Okay, these are just relatives and family members helping the patients. Okay, in washing and their hygiene or their daily activities. Okay, so this one, okay, okay, wearing of appropriate slippers maybe can help. Okay, so anyway, that ends my discussion. Thank you so much for listening. God bless everyone.